speaking from my office in Palm Beach, Florida. Appreciate likes, subscribing, and as many comments as possible on this particular video. I'm going to be doing a video on post-traumatic stress disorder. This is an interesting one. I think it affects so many people as we live in a dangerous world. So the plan here is to run through 6 basic areas describing post-traumatic stress disorder, and then I'm going to run through prevalence, risk factors, pathophysiology, anatomy, treatment, and where the future's going. So let's get into the gist of it. What are we talking here? Post-traumatic stress disorder, PTSD. I had a patient, this reminds me, he was an engineer on a train, and he was going up and down the east coast of the United States. And one day, there was a woman on the tracks. She was standing up on the tracks. She had just jumped in front of the tracks. Obviously, this woman was committing suicide. And the train wasn't moving very fast, maybe 60 or 70 miles an hour. It wasn't like the Bright Line. It was just your regular train. And he had a cup of coffee at his seat while he was operating the train. And the train hits the woman, and I don't even want to get into what happened to her, but she died, and there were just body parts everywhere. And he said when he looked at the coffee, there were no even ripples in the coffee. There was no sound that he heard. There was no even movement in the coffee after he ran through this person's life, he said. And I had him in treatment for years after this event, but I'm going to describe post-traumatic stress disorder through this case vignette. And this engineer, the people at work gave him as much time as he needed. And he came to me, the next day after the trauma. And the trauma, and this would be a criteria, in post-traumatic stress disorder, the trauma does not have to directly affect you. Yes, sexual abuse, physical abuse, some horrific natural event, that's a trauma. But it has to be someone close to you that you witness or a family member. So that's one of the criteria for post-traumatic stress. Anyway, this individual came to me, and I saw him, and he initially took, I think, roughly a month off from work. And the first couple of weeks, he started getting a little jumpy and like hearing something or seeing something or looking at coffee or hearing a train. And he was getting like reexperiencing the event of running over the woman with the train. And I told him, this is common, but I don't think you have post-traumatic stress at this time. And he didn't. And then he was getting some waking at sleep, thinking, a little sweaty, reminding him of this terrible incident. And, in my mind, I said, this isn't progressing to post-traumatic stress as of yet, but he's starting to show symptoms. Anyway, after about a month, I had like 4 sessions with him. Once a week, he went back to work. And so he started working, and he kept seeing me, and he started getting real jumpy, or if I say jumpy, he was easily startled operating the train. He was always afraid someone else was going to jump in front of the train, or he was going to hit someone. This is another component of post-traumatic stress disorder. It's called hyperarousal. He became super vigilant of every sound, every smell. He looked around him. He got easily startled, easily frightened. He was very aware of his environments. He was getting a little angry sometimes. This is all part of post-traumatic stress disorder. A hyperarousal, hypervigilant, and for sure he was getting that. There was no question that for anything that reminded him of the accident or the trauma of running over that woman, he would get jumpy. And he was always on the lookout. He was always in a state of vigilance. He was getting angry. I was starting to show more signs of post-traumatic stress disorder. This easily startled, hyperarousal, hypervigilance, fear that there was always going to happen again, always scanning the environment, always thinking that something was going to happen. And this is a lot of energy for someone. And he never let his guard down. He was always tensed up. And then I started noticing like a pervasive negativity took over. Like, I'm blaming myself, he would say. He said, what's really upsetting me, he would tell me, I can't remember the fine details of everything. I forget exactly what happened that day. He would talk about, maybe it's going to happen again. Maybe it's my fault. The world's a terrible place. Things are never going to work out again. I'm never going to enjoy my work again. It was always negative. I can't have fun anymore. That's another part of post-traumatic stress. Talked about the trauma. Maybe he's getting hypervigilant and hyperarousal, but then this pervasive negative behavior of what's the point? I blame myself. I was the cause of this. The world is unsafe. No positive feelings, no positive emotions. His wife came in and said, he's very negative. Nothing's good anymore. Nothing works out. Everything's bad. Society's bad. Nothing is going to work out. That negative thinking is part of post-traumatic stress. It's the trauma, the re-experiencing the trauma. He started getting flashbacks, nightmares, and just hearing a train horn would set him off. He would become psychologically and physically overreactive to anything that reminded him of the trauma, the smell of coffee, looking at coffee, the train horn, the sound of the train, seeing his uniform. So now I say, okay, we're having problems here. We're about 4 months out, and he started saying, listen, I'm afraid to get on that train. I can't be getting on that train anymore. It just triggers me off, and I'm a mess. I'm a wreck. I can't drive the train. I'm afraid I'm going to hit someone. I'm afraid something's going to happen. I get on the train, and he goes, I just don't even want to go near a coffee shop or smell coffee, because it reminded him, there's nothing like being in therapy with this guy. Maybe I had him in therapy 50 hours, and he kept telling me over and over again, I was looking at that cup of coffee, and he saw the woman. He knew the train was going to impact with the woman. He said it seemed like hours. Time slowed down. He looked at the cup of coffee. The train went through the woman and she vaporized, basically. There wasn't even a ripple. I can't tell you, I had this man in therapy for so many hours. He kept telling me that over and over again. So at this point, we're 6 months out. He's had this trauma. He keeps getting nightmares, flashbacks. He's got this hyperarousal state where he's jumpy and easily angered and easily startled and overreactive. He can't sleep. He's anxious. He's negative. He's got emotional blunting. He's got that negative thinking, avoidant behavior, the hyperarousal. And it's been going on for months now. You only need 1 month to meet the criteria for post-traumatic stress. And I don't really discuss diagnosis with patients, but he had asked me one day, he goes, I think I have post-traumatic stress. And I said, I think at this point you do. And through that case, the pain of this individual, I can't quite tell you. He went from a guy's guy, he was meeting with the other conductors and he would hang out with them, to just an introverted, socially isolated, quiet, self-absorbed, negative, detached person who bags under his eyes because he couldn't sleep. He was always worried, hyper aroused, like always thinking he's tense. He'd be in the office and I'm like, I'm on the second floor and the leaves hit the window and he was always, what's that? Little kids would run by the hallway because I'm in a building where there's children. It's mixed use, commercial, residential. He's like, what's that? What's that? I'll get into the therapy component of how I dealt with those issues. But risk factors, this man did have risk factors. The risk factors for getting post-traumatic stress are, one, being female. He wasn't female, but two, having a difficult childhood or any previous traumas or unsupportive parents, a stressful childhood, previous episodes of abuse or trauma, or just a chaotic childhood. That's a risk factor. Having a mood or anxiety disorder is a risk factor. Being female is a risk factor. Having a substance abuse problem is a risk factor. Genetically, predisposition is a risk factor. So he had a chaotic childhood. He drank a little too much. Would I call him an alcoholic? He was coming home and he was a 4 beer a night guy. And sometimes on the weekend, 4 beers for, alcohol drinks. He was a whiskey drinker. So he was loaded for this to happen. But he would have never gotten post-traumatic stress had he not been in that train when that woman was run over. The prevalence of this, it's interesting with post-traumatic stress. About 6% of the population has it. That's about 7.8 million Americans. And it's interesting when you study these people and you look at them, let's go with pathophysiology, their norepinephrine is through the roof. That's the flight or flight neurotransmitter. Their glutamate, which is the excitatory transmitter, is very high. GABA, which is calming, is very low. Also, on an anatomical level with these people, the amygdala, which produces fear, is off the charts. It's overreactive. The amygdala, which is a brain organ, is producing too much fear. The hippocampus, which is a memory center, starts breaking down and not working right. And it starts not remembering the past from the present. So memories from the past seem like the present. So the trauma of running over the woman seems like the present. And then what happens? The anterior cingulate gyrus and the dorsal lateral prefrontal cortex, which is right here, which makes us human and not apes, starts not working right. And that's the calming part that tells you, no, this is false information from your hippocampus. These memories from the past are from the past. They're not the present. And the fear response from the amygdala is too much. Disregard it. And that part of this prefrontal cortex is not working. It's interesting because as science progresses, we can actually study these organs and see that they're not functioning right. In terms of treatment, well, back to the anatomy and pathophysiology. Instead of calling this post-traumatic stress disorder, we should call it brain-induced injury from trauma. Because clearly this is damage to the brain. And the brain can be damaged by psychological events. Just as the brain can be healed by psychological events. And then let me get into treatment. A lot of the treatment involves calming down the flight or flight response. You can do that with clonidine, which blocks norepinephrine release. It's a blood pressure medicine, but can be used to block that norepinephrine release. Prazosin, which can be blocked to stop nightmares. It blocks that norepinephrine release. Prazosin is an alpha-1 blocker, so it stops the system from shooting out norepinephrine, and the clonidine it blocks the alpha-2. It stimulates it, but causes a block in the release of norepinephrine because that alpha-2 receptor is an inhibitory receptor. Then there are drugs which we can use. Zoloft, which is sertraline, paroxetine, which is Paxil, and venlafaxine, which is effector, and desvenlafaxine, which is Pristiq. These drugs are antidepressants, and they're also indicated in anxiety. They can really, the combination of these drugs can be very beneficial. I wind up using other drugs. These people are so tense, I wind up using baclofen, which is unique in its effect on GABA and relaxing the muscles because they're very tense. I use certain antidepressants, trazodone, Sinequan for sleep. In some cases, can use mirtazapine, which is Remeron. This pharmacopoeia is extremely helpful. There are other drugs which I use. Ketamine, intranasal ketamine, S-ketamine, can relieve a lot of the symptoms of post-traumatic stress disorder. It's an intranasal use, and I use it once a week, and it works almost instantly. After one session, people calm down. The anxiety calms down. That sense of negativity calms down. Other things I can use are, this is not legal and I don't use it, but MDMA can be extremely beneficial. And using that while providing therapy can be very beneficial. Other treatments are transcranial magnetic stimulation. There are different types. There's a new one out, that's a rapid acting one, that's a 3-week protocol. There's the initial one, TMS, transcranial magnetic stimulation, which is a 6-week protocol. I think it's called the R or the I, rapid acting TMS, that's a 3-week protocol. Whoever does that, I don't really do it, but it's extremely beneficial. I've used it, and transcranial magnetic stimulation works. Also, there's the therapy. There's prolonged exposure therapy, where through actual presenting the person with real life situations that trigger off their post-traumatic stress disorder, or imaging techniques where you expose them to the stressful event that triggers off the flashbacks, nightmares, and reminds them of the trauma. You can use that, and through repeated exposure, desensitize that individual. That's part of therapy. Then there's cognitive processing therapy, where we take the dysfunctional thoughts and challenge them. My life is over, things will never be good, it's my fault, the world is dangerous, everything I do is wrong, nothing is good. You challenge these and reconfigure through cognitive restructuring these dysfunctional thoughts. Just as the mind can be damaged with psychological trauma, it can be healed through positive trauma. And I've seen it, and I've done it. This is 33 years later, I've been doing this, and I've taken through that engineer. I didn't get him back being an engineer, but he did go back to work, and I did make him a healthy person again. I think maybe he needed to get away from that train anyway. Because I had to stop his drinking, and I think doing the train was too tied in with his drinking too. And there's definitely things in terms of treatment that the alcohol is not good. And benzodiazepines like Ativan, Xanax, I'm not a fan. I would almost say I never use them in post-traumatic stress disorder. And I can't say never, because there's always that time when you wind up using it, but I really, 99% of the time, will not use it. There's some more interesting things going on with post-traumatic stress. Not all post-traumatic stress disorder is the same. There's complex post-traumatic stress disorder, post-traumatic stress disorder, and acute stress disorder. Acute stress disorder is if it's lasted if the onset occurs and it comes on in less than a month. If the symptoms are a month or longer, it's post-traumatic stress disorder. Complex stress disorder is when it's like in a military situation where you're faced with trauma every day for 18 months, or you've been sexually abused by someone every day for months or years. That creates complex. Simple post-traumatic stress disorder is one event. Like my patient who ran over the woman with the train, that's simple post-traumatic stress disorder. Where are we going in the future of treatment? The future I see where we're going to be able to measure levels and have markers and specifically tailor treatment to the specific biological markers, like in terms of the state of the amygdala, the state of the hippocampus, the anterior cingulate gyres, prefrontal cortex. What damage has been done there? What's the level of norepinephrine, epinephrine, GABA, glutamate, and tailor the treatment to specific biological markers. That's coming soon. So it will be patient-specific treatment, and then we will use genetics to determine which drug best works in that particular patient. And then not only will we use the blood to track these organelles functioning and levels of neurotransmitters, but we will use scans and decide where the area of damage is and how much the damage is, what part of the brain is damaged, and what exact part of that organelle of the brain, what part of the amygdala, what part of the prefrontal gyres. So we use scans and we'll tailor the treatment to heal that particular part. So as we stand now, since I did work in the VA for a while, I've seen a lot of post-traumatic stress, and I work with a lot of special forces, Navy. I worked on a naval base, Great Lakes Naval Base, for a while. So I've seen a lot of this post-traumatic stress. In my civilian practice, it was more sexual abuse, traumatic beatings, tortures, rapes, that kind of thing. Where in the military, it was witnessing and being shot at or blown up, especially the Persian Gulf Wars with the IEDs. They're always watching people getting blown up or entering places. I saw a lot of that. But anyway, I appreciate comments. I have a blog, drmarkagresti.com. The blog has got hundreds of new articles. I've got interesting stuff going on the blogs about diets for depression, diets for bipolar, specific treatments for post-traumatic stress. It's extremely interesting. I spent a lot of time on it. So anyway, I appreciate the comments, appreciate the likes, subscribe, and anyone needs an appointment, just call my office, 561-744-7044. Thank you.